First of all, I must give thanks to the course organisers for inviting me to give this talk entitled Catching Up with the Bechet's Challenge. It's a great privilege to talk to you about an area of my practice I'm so passionate about, and I'm sorry I can't do it in person and that we do not have much more time. First, let me quickly declare my potential conflicts of interest, which are summarised on this slide. So, here we see the learning objectives of the talk I give. I hope to achieve this during this talk. I've chosen to avoid case presentations and to focus on the key areas of interest ranging from typical and atypical features through epidemiology and genetics, the ancient origins of the syndrome, and summarising our approach to treatment and how this might develop, hopefully highlighting some important points along the way and stimulating you to read more widely about this fascinating disease that has taught me so much. So, pattern recognition and probability lie at the heart of making a diagnosis of Behcet's, since there is no diagnostic test. Aphthous ulceration is usually the first symptom of Behcet's in most cases. There is then a gap, on average, of 3 to 5 years, but sometimes much longer, before the onset of the second clinical feature. What happens during this period immunologically? We don't know, despite this being a critical issue. There are probably a population of patients, as shown here, with oral ulcers and genital ulcers who are part along this journey, but this is an under-researched area. Here are some of the patterns that we recognise that may be helpful from a diagnostic and prognostic perspective. So we see the male HLA-B51 positive patient with uveitis, usually at the back of the eye, and typically with oral and genital ulcers. Women who present with mouth and genital ulcers and erythema nodosum and arthritis. We also see a male population with mouth and genital ulcers and vascular complications, particularly DVT and vascular arterial involvement, sometimes associated with pulmonary arterial disease. Then we see some atypical cases, such as those of smokers who may have vascular involvement, ocular and neurobehcets or GI features, but there's a systemic onset. And then also we see systemic features in pediatric cases where there may be fever, and this might alert us in the children's population of patients to atypical presentations signalling atypical or monogenic autoinflammatory diseases which might overlap with Behcet's. Throughout all of these subtypes, there may be fatigue, sleep disturbance, and widespread musculoskeletal pain in features typical of fibromyalgia. And curiously, what we observe is that in general, over time and the course of the illness, adults generally get better, rarely presenting after the age of 50 as a new case, and in contrast, children may progress over time. Here we see in the green bubble the 53 million people in England, and I guess in Sri Lanka that will be 22 million. 20% of the population will have aphthous mouth ulcers at some stage, many of them recurrent, and that's a lot of people. At least 90% of patients with Behcet's will have a preceding history of mouth ulcer, just like aphthous ulcers in the 20% of the population, though sometimes they may be more severe and more frequent. We've recently completed and published a study on the epidemiology of Behcet's, which I would encourage you to read. This was based on a primary care database, the THIN network, which established that the prevalence of Behcet's was between 8 and 14 per 100,000 of the population, say about 5 to 6,000 patients in England, though this may be an overestimate as prior studies were 10 times lower than this. So what happens to cause a conversion from a simple oral ulcer to the onset of the second symptoms of Behcet's, usually a GU? And I'm sorry to say that we do not yet have an understanding of the mechanisms for this, though we have some ideas. The triad of genetics, environmental factors and their interaction with probability lie at the heart of this conundrum. We're also able to recognise atypical presentations, and one of the more fascinating findings to emerge from recent research from Turkish cohorts is the role that smoking has in linking to a non-aphthous beginning and a more severe, sometimes systemic onset of disease with vascular and vital organ involvement soon after presentation, and we've observed this in practice in our clinic. Here are the overarching principles from the 2018 EULAR guidance, which are also at the core of the National Behcet Syndrome Service, which I lead in Birmingham. The MDT approach to diagnosis is key, gathering together rheumatology, oral medicine and ophthalmology to assess patients with other specialties if required on the day. The goal of treatment is to promptly suppress inflammatory exacerbations and recurrences to prevent irreversible organ damage, which may happen quite quickly in the eye, the brain, the gut, and the vascular system. This also obviously facilitates a far more personalised approach to treatment. This is a forest plot of the prevalence estimates for Behcet reported by Alfred Marr's group, summarising 45 population-based studies and pooled estimates summarised in our TripAdvisor top 5 spots in the world on the right. Overall, the worldwide prevalence is 10 per 100,000. My estimate for Sri Lanka would be perhaps more aligned to the European numbers, say 5 to 15 per 100,000. We can see a huge variation with greater prevalence along the Silk Route, with prevalence falling 100-fold from east to west. Several studies have shown that for migrants they adopt an intermediate figure. Not all of this variation can be explained by genetic factors, which are reported to account for up to 16% of the risk. So what does this tell us about possible triggers that might vary across geographies? As we have no diagnostic test, we rely on pattern recognition and probability to guide us, first ruling out all potential mimics or alternative explanations. This is why the MDT approach is so powerful. Here we see the most commonly used 1990 ISG or Lancet criteria, side by side with the more recently published international classification criteria published in 2014. Both are points-based systems, but we can see that you can fulfill the criteria with oral ulcers and genital aphthosis in the ICBD criteria. Oral ulcers are no longer mandatory in the ICBD criteria. Usefully, vascular and neurological features can now be included as diagnostic features. However, I think that the time element and the way in which combinations of clinical features occurring at the same time or in sequence adds diagnostic weight, and this has not been captured in the traditional classification criteria, and that's where the human comes in, and perhaps AI in the future. So, one of the first things we did in Birmingham was to evaluate the performance of these classification criteria in a UK context, and one might do the same in Sri Lanka. Whilst we found that the new ICBD criteria had enhanced sensitivity, over 90%, we found that it lacked specificity compared to the 1990 criteria, which we now tend to prefer in the UK context, where Behcet syndrome is clearly far less common than in the Middle East. Here we see some of the variable clinical manifestations of Behcet's, and in the second column, how frequent they are, and after that, roughly when they tend to occur. Some of these complications tend to associate with more serious outcomes, as can be seen in the prognosis column. These adverse prognostic complications, such as ocular, vascular, neuro and GI disease, often develop unpredictably and suddenly. Why the Behcet disease behaves in this way we still do not know, but note that the GI involvement is more common in Japan and the West than it is in the Middle East. If we delve deeper into Behcet's itself, we also begin to see so-called subphenotypes, where, as we previously saw, particular combinations of clinical features tend to cluster together in the same patients. There are 3 or 4 clusters shown here. Extraparenchymal neurological disease is largely venous sinus thrombosis or aseptic meningitis, as opposed to parenchymal disease affecting CNS tissue. It should also be noted that in the Middle Eastern cohorts, ocular disease principally affects the back of the eye with panuveitis and retinal vasculitis, whilst in Western cohorts we perhaps see less severe anterior uveitis, which is becoming more common. These patterns or subphenotypes are increasingly recognized in international studies of cohorts of patients, There is more to be done in this regard in the UK, which the 3 Bechet centres together with my colleague Priyanka Chandrachi will be doing. International work has indicated that there may be an underlying genetic explanation for these observations, linked perhaps to pathways that might be relevant and shared with other immune-mediated inflammatory disease, particularly such as inflammatory bowel disease, and that this might be a basis for differing approaches to treatment. Here we can see how some of the combinations of clinical features of Behcet's that we've been discussing can masquerade as other conditions and cluster together. And as we'll hear later, these disease phenotype patterns and overlaps may have an underlying biological basis. I particularly point out the arthritis acne and enthesitis phenotype, which may mimic seronegative spondyloarthropathy patterns that have appeared in some cohorts. The GI Behcet's phenotype, which looks very much like inflammatory bowel disease and sometimes is extremely hard to differentiate from Crohn's disease. And then in children particularly, fever may be a presenting feature, and this may signal possibly autoinflammatory disease-like manifestations of Behcet's disease. And certainly in some of the studies that are going on now, we're delving deeper to look at this group of patients to look for monogenic signals genetically for this type of patient. Inflammation shown on this slide in the endothelium is a key feature of Behcet's disease, which is one of the reasons it's classified as a variable vessel vasculitis in the Chapel Hill nomenclature, and may lead to a variety of features and complications shown here. These often link together and are useful in pattern recognition, so we may see venous thrombotic disease associating with pulmonary arterial, aneurysmal, or systemic arterial vasculitis. The association between thrombotic manifestations in the venous system and arterial or pulmonary vascular lesions is important and known as so-called Hughes-Stevens syndrome. Intuitively, one might think that anticoagulation would be crucial, but as we will see, many studies have failed to demonstrate any added value from anticoagulation compared to immunomodulatory treatment. So in this slide, we see some results from our primary care-based epidemiology study. The one that I mentioned, we'd established an estimate of the prevalence of Behcet's above previously published figures. But the important point on this slide is that we can see that before the diagnosis of Behcet's was made, about 12% of patients had another immune-mediated inflammatory disease, then went on to a final diagnosis of Behcet's, and a third of those cases were inflammatory bowel disease. A much smaller number went on from a diagnosis of Behcet's to something else again, once again most likely inflammatory bowel disease. Keep this in mind when we begin to explore the genetics more deeply later on. This was a study that I found fascinating, reported in the last ICBD meeting using the Japanese Ministry of Health and Labour Welfare database. These Japanese researchers noted that the subphenotypes of Behcet's were changing in proportion significantly over time, with a rise in the GI disease subphenotype and a fall in the ocular phenotype. It's interesting to note also that in Japan and Korea, the incidence of Crohn's disease in particular is increasing, perhaps due to a movement to a more westernized diet, and we'll see later how Behcet's and inflammatory bowel disease, especially Crohn's disease, share genetic similarities, which might provide an explanation, since it may be sometimes extremely difficult to differentiate the two conditions. So in summary, we've learned that the clinical presentation of Behcet's is heterogeneous and may vary according to sex, country of origin, and age of onset. So let's now look more closely at the epidemiology and see how this links to the genetics and origins of Behcet's disease. So on this slide, you'll now be familiar with a several 100-fold difference in the prevalence of Behcet's comparing Northern Europe with Turkey. Not all of this variation can be explained by the population frequency of the major risk allele HLA-B51, which mirrors the frequency of Behcet's as it falls from east to west along the Silk Route. The geographic variation of the Behcet's phenotype that we have discussed is debated, but it is interesting to note that in this context the nature of Behcet's does appear to be changing, especially in Japan, particularly with the GI phenotype increasing and the ocular phenotype decreasing as the worldwide incidence of Crohn's disease increases. As you can see, Sri Lanka is not identified as one of the endemic areas, but it would be of great interest to study the epidemiology, as I don't believe that this has been done. So approximately 130,000 years ago, and possibly at other earlier times, researchers indicated there were more verdant phases in Africa which linked to changes in the natural environment and wildlife, and which triggered migrations of early hominids, including Homo sapiens, who began moving north out of Africa, going east and west and encountering and interbreeding with the more archaic humans, the Neanderthals in Europe and the Denisovans in Eurasia, who may have originated from earlier hominid migratory events from multiple sources in Africa. It's currently thought that a significant chunk of our immune regulatory genes within HLA were acquired from these ancient humans, including HLA-B51. This is something known as introgression between the species. In 2001, Peter Parham's group at Stanford found that some of our HLA has ancient origins from interbreeding with the Neanderthal and Denisovans, and these ancient alleles, including B51, had strong ligands for natural killer receptors. In 2013, Dan Kastner and Elaine Remmer's group in Nature identified that there was an epistatic interaction between B51 and a molecule called ERAP1 on a different chromosome, which is polymorphic, and that trims peptides for antigen presentation on the class 1 molecule, including B51, so selectively shaping the peptidome towards a more loosely bound conformation and suggesting a link with microbial antigen processing and presentation and the regulation of natural killer function. So for Behcet's disease, the class 1 allele B51 and B5 remains one of the tightest known for a polygenic disease genotype, interacting with an odds ratio of nearly 6:1 in meta-analyses. What you may also deduce from this slide is that B51 can serve no useful purpose as a diagnostic test, as 18% of controls overall were B51 positive, and the figure for this is roughly 11% in the UK. Some authors, including McGonigal and Ahmet Gul, have postulated a shared pathogenetic pathway between Behcet's and the spondarthritides, with a breakdown in barrier function at mucosal and other surfaces. Research has also shown that there are shared links with psoriasis and inflammatory bowel disease involving the IL-23 receptor and IL-10 polymorphisms. And note that the epistatic ERAP1 reaction operates in different directions for Behcet's disease, psoriasis, and ankylosing spondylitis. So putting this all together, some researchers in the USA have combined all of the genetic studies of Behcet's, performed some additional epigenetic studies, and come up with this graph which summarizes the total genetic risk score and tracks how it varies according to populations. They estimated overall that there was a 16% genetic contribution toward the risk of getting Behcet's, so you could say that a large amount is still unexplained. It also shows by the green line how much can be explained by the known HLA, that's 40%, that's associated with B51. And we can see that the risk is reduced amongst African and African American populations, perhaps because these populations have inherited less ancient DNA from our forebears. I guess Sri Lanka is likely to be intermediate. Here is some more fascinating recent research from some American researchers. They studied the genetics of patients with Behcet's on the one end of the spectrum and simple recurrent aphthous ulcers on the other, and something in between called the FAPA syndrome, periodic fever, aphthous stomatitis, pharyngitis, and cervical adenitis, which is the most common periodic fever syndrome in children. Now it's interesting to note that FAPA shares risk loci for disease at IL-12A, STAT4, IL-10, and CCR1, CCR3 with Behcet's disease and recurrent aphthous stomatitis. And it's the differential HLA associations along this spectrum which were thought to determine where individual phenotypes fall along the spectrum. So these genes might help to determine whether subjects with aphthous disease progress along the spectrum toward Behcet's. We would like to do some research in this area ourselves. So what does this all mean? Well, summarising it all, knowledge of the genetics has not yet resulted in any major changes to treatment, but we can see that elements of the Behcet's phenotype overlap with some conditions, that these conditions may share genetic similarities, and these particular conditions include Crohn's, inflammatory bowel disease, psoriasis, spondyloarthropathies, and reactive arthritis. It's reasonable to speculate that some of the biology might overlap, and differentiating them clinically might be difficult. It's also interesting to consider that targeted treatments might be used that are based on common pathways which are shared between these conditions. So that neatly moves us on to the treatment, and as we saw earlier, if we delve deeper into Behcet's itself, we also begin to see so-called subphenotypes, where, as we previously saw, particular combinations of clinical features tend to cluster together in the same patients. There are 3 or 4 clusters shown here, which are increasingly recognised in international studies of cohorts of patients. There is more to be done in this regard in the UK, which the 3 Behcet's disease centres, together with my colleague Priyanka Chandratre, will be doing together. International work has indicated that there may well be an underlying genetic explanation for these observations, linked to pathways that might be relevant and shared with other immune-mediated inflammatory diseases, particularly inflammatory bowel disease, and that this might be a basis for differing approaches to treatment. We don't have time to go through the full EULAR guidance, which has recently been updated, but I would encourage you all to read them, so I've put this on your reading list. So in this slide, we see a summary of some interesting work that was done from an Italian and Turkish group that is based on this concept of a subphenotype-based approach to treatment. It's based on a review of the literature and proposes that our treatment pathways should vary for Behcet's, as shown here. For mucocutaneous and articular disease, we would avoid tocilizumab and cycle through colchicine, azathioprine, the anti-TNFs or interferon alpha, then IL-17 and IL-1 blockade. For vascular disease and non-parenchymal CNS disease, including cerebral venous sinus thrombosis, the role of anticoagulants is contentious, but we would use more potent agents up front, including cyclophosphamide for aneurysmal disease, with anti-TNFs as second line. For parenchymal CNS disease and ocular disease, we would avoid cyclosporin A because of a risk of exacerbation of CNS disease, which is established in case reports in the literature, and we would use early steroids and azathioprine and TNF inhibitors up front for resistant or severe disease at presentation, holding tocilizumab for refractory disease, particularly where there is macular edema. Here we see some recent evidence supporting the targeting of IL-17 pathway with secukinumab for mucocutaneous and articular Behcet's. Previous studies, however, led by Andrew Dick's group in Bristol, showed little evidence of efficacy in ocular disease in Behcet's. So we are now exploring a randomized controlled trial of secukinumab for non-ocular Behcet's disease in the UK through the 3 National Behcet Centres of Excellence, and this work is being led by my colleague in Liverpool, Rob Moots. So here we see some recent data supporting the efficacy of ustekinumab in mucocutaneous Behcet's, an agent that targets IL-12 and IL-23 through the common P40 subunit and works also in Crohn's, psoriasis and psoriatic arthritis. We can see improvement in both number of oral apathy and Behcet syndrome activity score, so this agent also shows promise for particular subtypes of Behcet's. Here is our current Behcet's disease drug pathway, which you will be able to find on our National Centre of Excellence website if you Google it. We step up from less complex mucocutaneous disease through ocular to severe systemic disease and pretty much our pathway reflects the EULAR guidance. More recently, however, we have made a proposal which we have put before our commissioners for an evolution of this pathway towards a more subphenotype-based approach. The current pathway has always used an approach varied by phenotype, but now we've extended this further, pretty much in line with the Italian and Turkish authors' work shown on a previous slide, as international evidence now suggests evolving further to a more individualized subphenotype-based approach is appropriate. In this evolution of our pathway, the choices for the first and second line therapeutic agents will continue to be based on the current EULAR guidance and the principles underpinning our current treatment pathway. Anti-TNF therapy will remain the first choice for treatment of refractory disease or treatment intolerant, or for those with poor prognostic features at presentation. However, where such approaches fail in approximately 20% of cases who commence anti-TNF therapy, a more tailored subphenotype-based approach would be recommended, depending on the disease subtype. In other words, we would perhaps switch to another class of biologic agent, depending on the subphenotype. So from multiple studies from all over the world, we've learned that our Behçet's disease constructs are not necessarily homogeneous entities, and that from a therapeutic and outcome perspective, functional pathways and their relative dominance within phenotypic clusters within Behçet's are more likely important. We do not yet have any reliable prediction signatures to help us diagnose, predict outcome, or response to treatment, but this is likely to come through the study of metabolomic and epigenomic and genetic markers, and there are some promising data emerging internationally on this. So what about the atypical cases that I mentioned in my earlier slides, particularly in children? Those that have a family history, or perhaps a history of fever or systemic onset, or those where there's consanguinity in the family, particularly in paediatrics. How do we spot these cases genetically? Well, what this slide shows is that for alleles with a frequency of less than 5% in the normal population, GWAS studies are unlikely to be helpful in picking up these signals. And next-generation high-throughput sequencing and whole exome sequencing used in a targeted way, particularly where there are familial cases, is useful and informative. And through these sorts of approaches, subgroups with atypical features are now been found with evidence of monogenic autoinflammatory involvement at the genetic level. So this approach would pick out rare variants of small effect size that are very hard to identify through GWAS studies. We're collaborating on this, particularly with our childhood cohorts at the Birmingham Children's Hospital with Paul Grogan's team at Great Ormond Street. So I will end my presentation with two slides, first with Paul Brogan's work using this technology. His team have recently published a series of 11 paediatric cases with atypical features, at least 9 of whom turned out to have definite monogenic mimics of the Behçet's phenotype. So as the authors say, there is clearly more work to be done in this area, both in the paediatric population with Behçet's and in other adults. So watch out particularly for these cases who have disease onset below the age of 5, where there is a family history or a history of consanguinity or an atypical course. This slide essentially shows some of this type of work done recently and reported in Nature from a Spanish group using next-generation sequencing to look at the frequency of rare polymorphisms for the known variants in 7 inflammasome-related genes associated with known autoinflammatory diseases. You can see that they were found frequently in 355 Spanish Behçet's patients in this study. 62 mutations were found among the 355 Spanish patients with Behçet's, and at least 38 of them were potentially pathogenic. This once again suggests that rare mutations in the inflammasome pathway may be more common amongst Behçet's patients. So as we mentioned, we're likely to see more of this type of work emerging in the future, and I know that Paul Brogan's team is leading this. So in conclusion, the MDT approach is a key design principle to aid treatment decisions and diagnosis in Behçet's disease. We must think of Behçet's as a construct with complexity in biology and overlap with other immune-mediated inflammatory diseases, as seen in practice in our GP-thin study. Clustering of phenotypic elements in time and in sequence may aid treatment decisions, and this is something that humans can do, and perhaps AI can do as well in the future. Highly targeted biologics unravel the biology, so it's important to keep curious for subpopulations of patients who don't respond in the typical way. Finally, we must remain vigilant for atypical features which might signal monogenic mimics of Behçet's, particularly those under the age of 5 or with a family history, and particularly in paediatric presentations. The diagnostic journey to Behçet's frequently includes alternative immune-mediated inflammatory diseases with overlapping phenotype and biology, particularly inflammatory bowel disease in a third of such cases where clinical differentiation may be challenging. Common underlying susceptibility genes may underpin this phenomenon, and there's much more work to be done on this in the future. The overlap with inflammatory bowel disease might also account for some of the higher prevalence of Behçet's that we have observed in our primary care database studies in England, and Priyanka and my team in Birmingham are exploring this further in further epidemiological studies. Finally, I'd like to thank my colleagues, many of whom are highlighted on this slide, without whom I wouldn't have got my thoughts together about this condition, and we wouldn't have done much of the research work, some of which I've published in this presentation. So, I will finish on this slide, which summarises some of the future challenges to be addressed in the Behçet's field. I'm so grateful for the opportunity to deliver this talk and hope that one day I'll be able to do so in person, perhaps with the results of our more recent studies. I will be happy to address any questions if there is time.